Wonderful. Well, thank you very much for being with us today. My name is Ed Davies. I'm a journalist at Reuters and a president of the Jakarta Foreign Correspondents Club. We are very grateful today to have Indonesia's Minister of Health, Budi Gunadi Sadikin, as a speaker, particularly at such a difficult time as this, and one that could be one of the most critical phases of the pandemic, and with the new measures about to be rolled out, as you referred to. Just a quick recap on the minister's career. He's a graduate of the Bandung Institute of Technology in Nuclear Physics and studied in Singapore to become a chartered financial consultant and chartered life underwriter. He began his career as an information technology officer at IBM in Tokyo, and then went into finance with senior roles at Bank Bali, ABN AMRO, and Bank Danamon. In 2006, he joined Bank Mandiri, where he became president director in 2013, before becoming an advisor to the Minister of State-Owned Enterprises, and then chairman of the State Aluminium Company and group chief executive of the State Mining Holding Company, Inalum, when you spoke to the JFCC at that point. In Jokowi's second term, he became vice minister at the State-Owned Enterprises Ministry. And in fact, I believe on the day he was last talking to the JFCC, he was announced that he would head the COVID-19 Economic Recovery Task Force. And in December last year, he took on what I think we can all agree is an enormously challenging role of health minister during a pandemic. So without further ado, I'd like to open the floor to the minister.
Since we have not much time, so I think it's better if I sit here and listen to your questions and I answer your questions. So that will be much more effective. Please.
Okay. Well, we have, well, thank you for doing that. We have some questions that were sort of put in earlier. Some of them cover the same area, so I'll try and sort of lump them together. But everyone else, you're welcome to put questions in the group or raise your hand, or however you want to ask questions at this this very interesting and important time. So perhaps if I could just kick off with a number of questions we had, including from Reuters, from Nikkei Asia, from AFP, for instance, were all around the Sinovac vaccine. I mean, we've had rising infections and deaths of health workers who have been vaccinated. So I suppose the question is, do you have doubts over Sinovac or Chinese vaccines in general? And what can the government do about this? And, what's your next move over this issue?
When I received these questions, I have several favorite charts. I don't know whether my assistant can show it to you as quickly as possible, but you can get this in one world data, actually. The first chart is the last 2 months of Israel confirmed case. I think, if I'm not mistaken, is going up by 4 times or 5 times. And Israel is the fastest country, to be vaccinated by Pfizer. And the second chart that I have, and I'm still looking at it, is the case where it is the case where UK also happened. It's increased another six times. And now their daily confirmed case exceeded Indonesia, vaccinated by AstraZeneca. The same thing happens in Australia, so I don't know whether you are from Australia. So the issue that we are facing is not about it. Yes, there is a difference in efficacy between vaccine, but it is primarily because of the Delta variant. It hit every countries. Udah dapat. So that is my view. So nobody is safe. United States is now in the best conditions, but for me that have seen many things happen with its variants, I will be slightly be more conservative. I will be more conservative. This is Israel in the last 2 or 3 months. So increase 7 times. Pfizer. You go to London, AstraZeneca. Yeah? London. If you make it bigger, 2,000. Now it's at London, if I'm not mistaken, it's 20,000 already, 22,000. 11 times. 11 times. The same thing with Australia. I have another data in Australia. Yeah, although the numbers is small, we start the bigger numbers, but at least the multiplications of the transmission shows that it happens everywhere. It happens everywhere. So in Indonesia, I have another chart showing that yes, it's increased drastically, but the people that have been vaccinated, you reduce the risk of being severe to mild, and from mild to asymptomatic. We also have the data that the number of deaths that we have on the second wave compared to the first wave, it is actually in terms of percentage is less. It's less. Okay, Ed. So that is my first explanation to you.
Okay, and in terms, just to follow up to that, I mean, does that mean that, I mean, you know, I realize, I understand that it's very early days with some of these vaccines to tell how efficient they are with new variants, but does that mean Indonesia will look at different vaccines in order to spread the, you know, the different technologies, if you like, that may stop these variants?
So we have bilateral contract and multilateral contract. The bilateral contract with Sinovac is 125 million doses. We have bilateral contracts signed already with AstraZeneca for 50 million doses. While Sinovac stick to their commitment to deliver 125 million doses by the end of this year, AstraZeneca failed to meet their commitment to deliver 50 million by the end of this year because whatever problem that they have. So they're only able to send 20 million by this year and the rest is next year. The third contract that we already have is with Pfizer, 50 million doses for this year, that hopefully it will start coming on August until December. The fourth contract, bilateral contract that we have is with Novavax. Before we believe before we plan they will start coming on July, but they have a delay in their approval, EUA approval under FDA. And again, it's still the contract, they will deliver 50 million doses by the end of this year. And then we have another multilateral contract with COVAX Gavi. Before, we are expecting to receive 54 million free vaccine under COVAX scheme this year. But now it has been confirmed at the minimum, we will receive 108 million of COVAX vaccine. And it is mostly AstraZeneca or Pfizer. We have some grant. The one that is just being received from Japanese government yesterday was around 2.1 million AstraZeneca. From US government, hopefully we will receive by this weekend 4 million of Moderna. And from Australian government, they're 77 million US dollar. In terms of vaccine, hopefully we can get it 10 million. We are still finalizing the deal with UNICEF, the vaccine provider. Most likely it will be either Pfizer or AstraZeneca. So in terms of, and we have the Gotong Royong scheme. It's not under the government program, but corporations can buy, and they have 2 vaccines, Sinopharm and CanSino, under their programs. So actually we have a variety of vaccine. For your information, the 181.5 million target populations that we would like to vaccinate is 100% not 70%, is 100% of the populations above 18 years old. Because we use average efficacy of the vaccine 60. So we use a very low efficacy of our vaccine to plan how many people should be vaccinated. So if we use 60%, which I believe our average will be higher than 60, because Sinovac is around 60, AstraZeneca is around 70, Pfizer and Novavax is close to 90, Moderna is above 90, then the average will be most likely 70 and 80. We have enough buffer. So we will vaccinate 100%, not 70% of the populations above 18 years old. Thank you, Ed.
Thank you. And just a quick follow-up on the vaccine issue. Is there a prospect of health workers getting a third dose of Sinovac or another vaccine, just because obviously they're at the front line of all of this?
That is a topic that I cannot disclose in this forum.
Right. Okay.
So you can guess the directions that we are doing, but actually that is not something that we can disclose in this forum.
Okay, thank you. A question from Ismi Damayanti of Nikkei Asia, who's on the JFCC board. I think she has a simple question. Do you think the latest restrictions are too little, too late? And we know that there was a lot of division in the government and it's a complicated issue to bring them in. But previously you predicted the peak of case transmission after the Lebaran holiday will occur by mid to late June. And obviously it's, that seems to have been pushed back. So I suppose it's just, are these restrictions going to be enough?
So first, I would like to do some corrections. If you do Google, what I said at the beginning, always it will peak by first week of July.
Okay.
I never told anyone that it will peak by mid of June. The reason why, I'm not a medical scientist, but I'm a physicist. We believe in empirical data. So last wave data, the peak happened between 5 to 7 weeks after the holidays. So 5 to 7 weeks after the 13th of May, it is around the first week of July. I have something to consider though. Because of the Delta variant, things might be different with the first wave. What I have been observed is the speed of acceleration is different. Delta is faster, it's much faster, the transmission rate. But again, for me, mostly the peak is not the downturn, but the peak, so we can start flattening. My estimation is first week of July based on the previous wave. Second, whether it's too fast, too late, if you ask me, if we can do it faster is better. But again, there are a lot of discussion happens, and there are a lot of inputs also being considered. And to be fair, whereas as a health professional, we see that we lock down faster is better. But from other perspective, if you see there are many people at the low level, the bottom of the pyramid, that if you ask to them, because in the last 14 days, I was asked by the president to go to the poorest places in Jakarta. I believe Ed Davis, as the JFCC president, never been to these places, the Rusun in Tanah Tinggi, in the middle of Pademangan, where 10 people live in one small houses together. They share single bathroom for 2 families. So in those people, if I ask them, so this is not a middle class and above. Middle class and above, lockdown as fast as possible. But if you talk to 60 or 70% of the Jakarta population at the lowest level, the bottom of the pyramid, but we need to live, and we need to work to live. So that is something that we found to them, and then that is what we believe gives some input to the government to make decisions, and finally we come into this decision. It is not an ideal situation, I would like to say, but at least we move forward and making this decision.
Thank you. Pete Brieger at Agence France Presse had a question about oxygen and reports of the price of oxygen rising and shortages in Jakarta.
Hopefully we can share the presentations to you faster. Itu di close. Total oxygen production in this country is 866 million. Can someone close the materials? Can someone close the screen, please?
We can see the oxygen.
Can you see the screen? Because I saw something here.
I could see a screen with oxygen figures on it.
Can you see the screen with this? Okay.
Yeah.
So our production is 866 ton per annum. And we are not up to that capacity. We are only producing 600 something because, sorry, I couldn't see this because it's closed by another funny screen on my screen. You bring your laptop to me so I can see this. Yeah? And then what is being used for hospital is only 185, if I'm not, 181. So most of the oxygen is used for industry. So the first commitment that I received from the Minister of Industry is to transfer from allocation from the industry to medical. So we still have rooms there. Number two, we also have commitment from the producer to increase the capacity from 639 to 866 million. So that is the rooms that we have. Yeah? And those are the names of the companies that produce oxygens. And this company has been approached by the ministers so the ministry can help them delaying the contract with the buyers. So instead of canceling the contract, the government will intervene and delay the delivery of the oxygen instead of the industrial, but focusing on the medical. The issue that we have it is a different location. So most of the factory is located in West Java and East Java because a lot of industrial that need oxygens are there. Only a very minimum in Central Java. So we anticipate already about 2 weeks ago that we will have a logistic issues to distribute. Have a problem to distribute. That's why we work with the police and army to make sure that all the ISO tank is being helped so they can distribute from West Java oxygen plant and East Java oxygen plant to Central Java. So that is our first problem. So you might heard that the first problem appears in Solo and also in Jogja. So if you take a look on the right-hand side, that is the locations of the factory, the oxygen factory. Central Java is very small and the utilization is already high because they don't have a lot of smelter or steel industry there that consume a lot of oxygen. So we need to redistribute ourselves. Yeah? And the second issue is most of this hospital is a wholesale buyer. So they have a gas installation. Now we have to change this into retail distributions because small hospitals require this oxygen. They don't have oxygen installations. And also they use many emergency room as bed. So they need oxygen not as installation basis, but in a tank. It's what do you call it? Small tanks.
Yeah.
So what the problem is becoming that we need to have logistics, different set of logistics. Have a different set of logistic to distribute the oxygens. So now we are asked the team to improve this different logistic. We are selling to the wholesale. Now we are selling to the retail. What we have done is actually mapping each of those hospitals with the producers. And we have an example in Central Java. A sample in Central Java, and it is managed together with the Central Java governor, and we will replicate this to all regions. Right? Make it bigger. So we have done this last week. Make it bigger. So like example, these are all the hospitals that we have in each of the cities, and then we map them with the distributors. Why don't you move to the left? So we have the different distributor have a dedicated outlet, dedicated supply to each of the hospitals, and we replicate this for all regions in Java for all the hospitals. Hopefully that answers your questions.
Okay, thank you. Just the last couple of questions that were pre-submitted.
What I need, so sorry, Ed, what I need your help is this has happened in banking. Some medicine and oxygen become rare and prices increase because rush happened. It's similar in banking. When people are panicked, they want to withdraw cash, which actually they don't need. We noticed this also in oxygen and medicine in the last 1.5 weeks, because everyone is panicked. They want to buy oxygen, which is actually they don't need oxygen. They need oxygen when they go to the hospital. They don't need to put them on their houses. So everybody want to buy oxygen because they feel they are safer if they have an oxygen tank. That creates an issue because a rush happened. So we need help also from all the journalists, including foreign journalists, not to let this bigger and create uncertainties, in requirements of oxygen's logistics. Please add.
Okay. We have a question from Marshall Rumlak at Merit International on whether standards for the self-isolation period will change from 5 days to 14 days because of the Delta variant. And I suppose this would apply to people sort of entering the country or something.
When we impose 5 days, I receive a lot of calls, many from the executive of the foreign companies that you are represented. That's why we are doing it. If I'm going to China, they will squeeze me in. As a minister, 14 days you cannot get out. The same thing when I came to Korea. But when we are here, I have a lot of requests for exceptions. And not only for foreign CEOs, but also for many people in Indonesia. Well, as in other countries, I believe in Australia, they also do the same thing. Australia is even tighter. So I think, yes, we are considering that. And I do hope all the foreign journalists also help us. That many countries are doing it. And if we are disciplined in implementing this, it will be good for everyone. So by asking exceptions, it's actually not a good practices. So if you can help us, sharing with many other people, including the most powerful CEOs of the companies that are willing to come to Indonesia, that will be very helpful. Thank you, Ed.
Okay, we have a couple of questions from Deutsche Welle and Vale and also from AFP about just the hospital system and how it will cope. Obviously, doctors are complaining of fatigue and exhaustion, and patients say they can't find rooms. What's the government gonna do to help this situation?
So we have 389,000 hospital beds across the country. So back in March, I issued a decree that 30% should be dedicated for COVID. So 30% of 389 is around 130 million. So can you make it bigger can you make it bigger, but focusing on before the Lebaran, so before the uptick. So yeah, you show the date. So Lebaran was in 13th of May, right? 13th of May, we have 389,000 beds. We dedicated as COVID-19 beds 75,000 beds nationally. Out of the 75,000 beds, 23,000 was occupied. So we plan already the 75,000 because we understand after Lebaran, whatever we did, we try as strong as possible to reduce the traffic, but we know that it's still happening. So we have 3 times buffer. So 75,000 beds compared with 23,000 occupancy. 2 weeks after Lebaran, it started increasing, and now you go to the right, paling kanan, and now it is already 74,000 beds, increase on 23,000 on Lebaran 13th of May to 74,000 now. Because of the flexibility buffer that we already have, we can increase on daily basis number of isolation beds. As I mentioned to you, we prepare 75,000. We planned before the outbreak, but we do have capacity until roughly 130,000 beds. So what happened? It started increasing very, very fast because of the Delta variant. We increased also the isolation bed. Now our isolation bed this is 2 days ago the figures, if I'm not mistaken, because I remember yesterday it's already 76,000. 2 days ago we have 92,000 beds with 34,000 occupied. So actually, and we can move this up until 130,000 easily, actually, on daily basis. The issue that we have, can you go down and show Jakarta numbers? It's because it is not well spread. Ada bornya nggak ada? Because some of the provinces have much worse situation than others. Like example, Kalimantan is only 20%, 30% more, but Jakarta, is 92%. So while at the national level, I'm pretty safe, but at the provincial level, it is not, because they do have differences. The outbreak did not happen equally. The outbreak only happened in a certain epidemiological area where they have a major Delta variant, which is Jabodetabek, Bandung Raya, Kudus. Now we start seeing in Jogja and Bangkalan, Surabaya. They are not there yet in Bali. They are not there in Kalimantan. They are not there in Sumatra. They are not there. So as you see, this is actually a problem. It is not well spread. So some of the provinces have a very low bed occupancy rate, but the other provinces are very high. So basically DKI Jakarta and West Java and Central Java, they have a very high concentrations, especially DKI. So what we did in DKI Jakarta, we convert all of the emergency room to become hospital bed. and we move emergency room to the 10. We try to take out the mild patients out to Wisma Atlet. We have 7,000 beds there, and we add additional 7,000 isolation beds in Wisma Nagrek and Wisma Rumput. So now on the isolation bed, we have 14,000 instead of 7,000 in Wisma Atlet. And we move the asymptomatic patients to the Nagrek and Pasar Rumput, and we plan to use Wisma Atlet as a backup hospital for Jakarta for a mild case. We are now considering also to make either Istora, Senayan, or Kemayoran, JFCC, that is capable up to 20,000 beds. If then we need additional emergency bed for Jakarta. So that is what we have done.
Thank you. A question from John Macbeth at Asia Times, asking, does the government's interest in ivermectin suggest it is seriously considering its distribution throughout Indonesia?
So the Ministry of Health position is following WHO. So there is no conclusive yet whether this medicine is effective or non-effective. And although I'm not a medical scientist, but I believe in science, so my approach is, let science do this. The debate should not be in social media, it should not be in the parliament, it should not be even in formal media, it should be between the scientists. I have made the decision, I asked from BPOM, a formal clinical trial will be done by the hospitals, the government hospital. Maybe we will do 10,000 or 20,000 participants to do a clinical trial for ivermectin quickly. And it will be under the strict guidelines and the professional teams to manage this clinical trial. And from that clinical trial, let science tell the truth, whether ivermectin is effective or ivermectin is not effective. And I do hope that the media can talk more about science rather than conspiracy theory on this one, because it is. I learned something. Physics and medical science is basically the same. You need to see the real basic, the evidence. You need to see the evidence-based scientific proof that is proper or not. So I just wait for the clinical trial and see whether it is effective or not effective.
Okay, thank you. A question from Ismira Lutfia, who for the Bangkok Post. With restrictions PPKM imposed across Java and Bali, what about the situation on other islands? Are they under the regular micro restrictions? And, I suppose there are questions some people have asked of whether these restrictions should have been across all of the islands.
We monitor daily using the WHO new guidelines. So 6 indicators for every provinces. Actually, we have it also up to the regency level. And so far, it is still under control outside of Java. So that's why this restriction, the PPKM, is for Java and Bali. And actually, not all cities in Java also have it. So like Ujung Kulon, they don't have these issues. Even, Cirebon, they don't have the issues, Banyumas, they don't have the issue in Central Java. So it's concentrated in a certain epidemiological area in Java.
Okay, thank you. This is a question from Wayudi at Straits Times, and also Don Greenlees of Asia Link was asking about the level of infections that would trigger Indonesia to end the emergency, and BOR, Wayudi was asking.
Sorry, I missed a little bit. The connection is not that good. Can you repeat again the question, Ed?
It's just a question about the level of infections that would trigger Indonesia to end the emergency.
the PPKM target is we would like to have the daily reduction reduced below 10,000, and we would like to see the positivity rate below 10%.
Okay, that's clear. Thank you. A question from the Sydney Morning Herald from Karuni. What brand of vaccines will be used for the under 18-year-olds?
We have 2 vaccines that has been approved, the emergency use authorization to be used below 18. One is Pfizer that has been approved between 12 and 17, and one is Sinovac that has been approved between 3 to 17. So we will use those 2 vaccines.
Okay, that's clear. Just a question about social assistance from Shataro Tani at Nikkei. Why, despite the experience last year and already having experience of handing out social assistance to the needy, could the government not take faster action to impose PPKM to coincide with the predicted 5 to 7 weeks after the holiday peak?
Sorry, I didn't really get the questions.
Okay, question was just really about why this time around, given the experience of last year, was the government not able to hand out social assistance to the needy? And, it had experience of this. Could the government not bring in the restrictions more quickly?
If the question is whether we will do social assistance, we will.
No, it was more about that since you've had the experience of doing that from last year, could not the restrictions have been brought in more quickly this time?
Oh, okay. The questions that why it's not being bring up more quickly is the same the same answer that I received at the beginning. Yes, there is a process in making these decisions, and it is not ideal. But again, what I can share with you, talking directly to the people, if you are talking to the middle class and above, they want to do it as quickly as possible. If you're talking to the poor people in the bottom of the pyramid, they're scared like hell if you do a lockdown.
Okay. From Chandni Vasandani at The Australian, how will you increase the number of tests daily to 400 to 500,000? And is there a plan to lower the price of antigen and PCR tests?
We will actually, we have more than 100,000 tests that we have done. Now we are doing around 100,000 to 130,000 tests per day for around 70,000 to 90,000 people per day. I strongly believe that we did more than that actually. We did 40 or 50% more than that. It is because not all tests are reported 100% to the system. Now we have identified, and starting this week, we will bypass the cascade reporting and go directly to the lab. So before it has to go, the lab has to go to the cities, the city has to go to the provinces, and the provinces reporting to us. And we believe some of the data are not 100% properly reported. So what we are doing now is going down to the lab, and my feeling we can increase this to 170 or 200,000 easily. And then we will boost that by putting a target actually. Lala bisa lihatin targetnya. We have a target for all 170 cities that they have to reach a certain test per day. If the positivity rate is above 35%, then they have to test 15 times WHO standard, which is 1 for every 1,000 people per week. But if their positivity rate is between certain numbers, 15% to 35%, they has to test 10 times. And again, if the positivity rate is below, so these are the target on the left-hand side. And then the right-hand side is the target for each of the cities. And for your information, we have 2 types of testing. The first testing is epidemiological testing. So it's initiated by the government. If you have a confirmation case, then you check the contact, the possible contact, suspect and possible contact, and it is funded by the government. But if you do testing for screening, like example, you want to see Ed Davis, and Ed Davis put a condition: before you enter my door, you have to be PCR free, or you have to be swab antigen free, and that is not the testing that the government will subsidize, because we call it testing for screening, not testing for epidemiological testing. We will fund the epidemiological testing. That's it.
Okay. A question from Henry Pranoto at Mandiri Securitas. He was asking about when can we expect the COVID case curve in Java to start flattening, do you think?
My answer, to be honest and to be humble, I don't know. Even many epidemiologists with all PhD have done it. If you Google, all of them make 1000% mistake. If you Google everyone with all the PhD in mathematical modeling. If anyone asks me, Budi, what do you think? I think, oh, it's easy. How fast we can flattening the curve? How many people less that got infected and goes to the hospital? How many people die because of this pandemic? It depends on us. If we are more disciplined in implementing the health protocol standard, and if we are rigorous enough to do testing and tracing, then it will be much better. Flattening the curve faster, lower number of people enter the hospital and death, and we can live happily. But if we are not disciplined, if our people is not disciplined, our family is not disciplined, our company are not disciplined, then it will take longer. So if you ask me, it depends on us. It depends on us, whether we can discipline ourselves executing the standard health protocols. The better, the faster.
Thank you. Just a follow-up question from Chico at ABC Australia, just on testing. Why couldn't we have had this higher level of testing in March to find and isolate more people with Delta? I mean, if the capacity was there, aren't we leaving this a bit late until things are bad?
I don't know whether my assistant can show it to you. We are improving our capacity day by day, 24 hours. Yeah? I give you an example. Itu yang I give you an example. When I joined on 23rd of December, I didn't see any variant, Indian variant or Brazilian variants. And if I ask my friends, the answer is because God loves us. Bukan itu yang capnya. So and this is next. Next lagi satu lagi. This is the testing history of Indonesia. So we keep improving, to be honest. Why don't you do it on March, Budi? I mean, on March, I'm still struggling with other things. Why don't you do it in Indonesia? Didn't do it in May. We are 2020. We are still learning. I mentioned to you when I joined on 23rd of December, we don't know that we have other variant of concern. Why? Because we only do genome sequencing by 140, whereas UK do 20,000. Singapore maybe do 6,000. So I realized that on the second week on this position, on the 8th of January, we established a network of 12 labs to do genome sequencing. Now we did 3,000 in 5 months, compared to 148 in 9 months. And then we have everything suddenly. We see the Indian strain, we see the UK strain, we see the Brazilian strain, If you ask me, what did you do it last year? We just don't even think about this. It is to be humble. We are learning by running. So we see, why don't you do it, do this on March? March, we are still struggling with others, lack of reagent, we don't understand the swab antigen, we know what are the good brand to buy, whether we have the capacity and competencies for our people to do lab. But as you can see, we are improving. So hopefully, if you are asking whether we can reach 400,000, with this track record, I believe we can.
Thank you. And I know you don't have very long. There was an interesting question from Linda Ulisman at the Straits Times about whether there's a possibility of inoculating children under the age of 12, given that we've had a spike in deaths of children recently. Including some who are below 5. So is there any prospect of that?
Still on mute.
Yeah, you're on mute, I think.
Case increase, yes, it is. Yes, it is. Whether the number of cases of children increase, yes, it is, because the number of cases are increased. But whether the number of deaths is increased, that is not the right information. So I do hope my fellow journalists also check the data with me. This is the data that we have. I don't know whether it's because of the Delta variant is less fatal, or it is the impact of the vaccination. I don't know yet. We are still doing some research. Next slide. So if you see by comparison, the percentage, I think is a much better comparison. It's not true that the percentage of death of children increased. Thanks, Ed.
Thank you. Just, I know you don't have long, a quick question, I think, from Natalia at AFR. Is there any update on the Merah Putih vaccine?
We have two good candidates. One is the candidate made by University of Erlangga with Biotis, a private companies. And the second one is the one produced by Eijkman and also Biopharma. To be honest, this program is chaired by the Ministry of Research and Technology. When the Ministry of Research and Technology is being abolished and moved to Ministry of Education, then we need to find the new format. So I've discussed with Pak Nadim and also Pak Eric, because those are three people sitting in the board. The chairman is Pak Bambang Brojonegoro, and I was a vice chairman, and Pak Eric is vice chairman, and we have a team. Now, because Pak Bambang Brojonegoro is being replaced by Pak Nadim, but the institution is gone, it has to be Pak. And we are still discussing in ourselves. Some bureaucratic discussions. Unfortunately, before we finish the discussion, I'm already discussing this, the second wave happens. So my time and energy is being shifted again, to provide beds, medical doctors, medicine, oxygen, and then, accelerate the vaccination programs. So you give me a good, reminder that I have to do something on this side.
Okay.
But the schedule so far is a second half 2022. And I only available for one more questions, Ed, if you don't mind.
Sure. We've got a question from Claire Jiao at Bloomberg News, who'd like to ask how talks are going in the WTO to waive the TRIPS for COVID vaccines. How can it help developing nations like Indonesia to get the IP and the technology transfer needed to battle the pandemic? I mean, a big picture question, this.
Indonesia has been active to become the co-sponsor of this TRIPS waiver initiative. And we have submitted is not only for vaccine, but also for therapeutics medicine. And we have sent a formal letter to my brother Tedros in WHO that Indonesia is extremely interested to build the vaccine production capacity. And I have one of my friends here sitting as the commissioner of one of those companies, Krisma Al-Banjar, that when I was the vice minister, I asked for 2 trillion or around 175 million additional equity injection from Ibu Sri Mulyani to build this facility. I do hope she still continue our aspiration when I was sitting at the Vice Minister of State on Enterprise. But what I shared with WHO, we don't need the money. We have the money, we have the expertise because Biopharma has been there and is also providing polio vaccine globally under WHO and UNICEF scheme. What we need is the access of technology. And we are ready to invest and build the mRNA or nucleic acid-based vaccine in this country. And some therapeutics, not only the chemical-based therapeutics like favipiravir, Avigan, or remdesivir, but also the biologics or biosimilar-based vaccine, monoclonal antibodies, from Eli Lilly or Regeneron. If they are open their patent, we are ready to develop the biotechnology-based therapeutics in this country. Thank you, Ed.
Thank you very much. And I'd just like to say, thank you again for being very generous with your time, which I know it must be a very, very challenging time for you and your whole ministry. So I think all of us wish you the best of luck and hope that the next few weeks progresses well, and we can see the pandemic at least becoming more under control.
Thank you.
And we'd love to have you on again soon. Thank you.